So I'm now very excited to introduce Dr. Mike Saag, Professor Emeritus at UAB, who will be presenting one of the highlights of this conference, his interactive ART cases for clinicians with a panel discussion. Thanks, Mike.
Great. Okay. So I'm Dr. New. Well, all right, so we're going to dig in and do case. I think a lot of you have been through this this exercise before. We have a robust panel here. Dr. Chu is back. Dr. Donna Sweet is here, and Dr. Kevin Carmichael are both long-term providers who have been involved in HIV care really since more or less the beginning of the epidemic in some form or fashion, and welcome them from Kansas and from Arizona, respectively. Dr. David Spach, who you'll be hearing from later in this meeting tomorrow from University of Washington. And Kim, you've already met. And then Dr. Hyman Scott is back from San Francisco. So we'll get started. That's my only conflict. So we're going to talk about starting regimens. We're going to talk about what to do when a regimen's failing, associated weight gain, HIV for people who are pregnant or want to breastfeed. Look at HBV, as we talked about that briefly yesterday, deferred to today. Trouble adhering to oral ART regimens, some skin lesions and fever, and primary care issues. So, a lot of you who have heard this before say, dang, I saw this lecture, the same questions. Yes, they are the same questions, but the answers change, and that's kind of the point. So we'll go through that. So what regimen should I use as initial therapy? This is a 48-year-old guy who presents newly diagnosed, asymptomatic viral loads, almost 300,000, low CD4 count. Other labs are normal. Genotype has come back as wild type. Normal renal function's okay to start therapy. You got lots of options here, including some injectables, or you could pick F as some other option. Go ahead and vote. We're going to get a red banner out and then get shot. All for a loaf of bread. Can you believe it? How'd that story ever make it? Okay, so we got a 90% answer here. Who wants to start? Yeah, Carolyn.
No, not me. I'm in the hot seat again next to you.
Oh, okay. So Kevin, we'll go to you.
I think it's a great answer.
Yeah, okay. Next question. What about starting with dolutegravir 3-TC? Anybody? The viral load's a little bit up. Thoughts on that, Dave?
Well, we have this luxury on this patient that we actually have a genotype. And I would say the reality is in our clinic, in most clinics, you're seeing somebody you're trying to get therapy started very promptly. So we usually don't have this. In this case, I would feel comfortable up to 500,000. I'd probably say in our clinic and most places, people are going to do big TAF FTC, but that is the one a little bit different thing here.
Right. So there was an abstract, I couldn't fit it in here, but it was in Glasgow about a week ago that showed that the original concern about even 500,000 maybe isn't such a concern. So that might be okay here, but you're exactly right. I mean, what's happening in reality, somebody gets diagnosed, they get referred to your clinic, you want to get them in just a few days. So we don't really have the ability to sometimes get same-day assessment, but within 3, 4, 5 days you get them in. You don't have much data, so the big TAF FTC is a good choice in that setting because it'll unless there's integrase resistance, which is a very low prevalence in the communities. You don't need to pull that, you don't need to worry about that too much. And then similarly, the dolutegravir with either TDF, FTC or TAF, FTC is a good option. Any comments about starting right away with raltegravir in this setting? The viral load's elevated. Yeah, typically you don't want to do that until viral load has been suppressed. Okay, let's move on.
Mike, the only other thing I would add is the one thing that did change in the guideline, what's not recommended now is dolutegravir, abacavir, lamivudine, or Triumec. So that was a demotion in the guidelines, so that's good for providers to know now that that's no longer considered a good option for initial preferred therapy.
Yes, I think that's a good take-home point, that it's not that abacavir is a bad antiretroviral drug. It works fine if there's a susceptible virus, but the concern about the cardiovascular events that are in almost all the longer-term studies is significant. It's not high, but it's significant, and you kind of shrug your shoulders and say, why are we going to go through all this extra testing for B5701? So you're right, David. It's in newer guidelines and perhaps some to be seen very soon in the next couple weeks. I suspect we might not see abacavir as a listed choice.
Can I ask you a question, Mike?
Yeah.
David makes a good point about not having a genotype when you first start someone on treatment, but then when you get that genotype back and someone's been on a fixed dose regimen for a period of time, could you then back down to a two-drug regimen?
Yeah, I think that's totally acceptable, and a lot of people do that, just especially if you're going to go to the dolutegravir 3TC. You might, if the person wants an injectable, once they've become undetectable, that's an option as well. So yeah, I think that's a great point. You're just getting it to gain a foothold, although as all of us have experienced, patients sometimes when they start, they're having success, they go, why do you want to change? And so it's good to have options, especially for those of us who've been doing this for a long time.
I think the other thing, though, is that you want to make sure they're covered for hepatitis B. If you don't have that information, that's really, really important.
Good point. So now we're going to look into the crystal ball a little bit. Great Scott, going to go into the future. Which regimen would you choose of these? And I'll just think the first three you recognize, and then lenacapavir orally with doravirine. Now, islatravir, I'm going to modify because there's more data that's just come out on islatravir with lenacapavir oral weekly. And so let's make that, because the every 6-month injectable really isn't too much of an option just yet. But then in the future, we might have a monoclonal antibody. You're going to hear about this tomorrow from Raj Gandhi. And then lenacapavir with cabotegravir, which really isn't available every 6 months, but if it was, is that something you'd choose, or so they come up with a new formulation or another version of it? Go ahead and vote.
Yeah, but if everything's
And they
fine.
reduced the dose, then they're coming out with the second generation.
Right.
Right?
But doravirine,
So it looks like there's a lot of enthusiasm for an every 6-month something. Yeah, why not? I guess, what do you all think? Carolyn, yeah.
Well, I don't have a crystal ball. I was thinking, I think what we do with these agents in 2 years really depends on what we're doing with them now. Honestly, I think I do get a little bit nervous with what I've seen so far about the resistance information with lenacapavir, and I do think sort of stepping outside the U.S., we're now really paying attention to dolutegravir resistance, given how many folks are receiving it, and I don't know how to answer this question, but that's what's going through my mind.
Others?
I think I would have probably gone with something else. I think some of the data that we have looked at for, what our patient preference is, a weekly regimen that's oral has really high acceptability. And so some of the data with lenacapavir and islatravir is a weekly oral regimen for a significant portion of our patients might actually be what they prefer. And I think that as we're seeing the mess that injectables have presented for all of our clinics, I think giving an option that patients want that also works with our implementation is actually going to be maybe a sweet spot that we can get to hopefully in a few years.
That's a great point. Kevin?
My father actually told me a long time ago, he said, never be the first doctor to use a new drug and never be the last doctor to stop using an old one.
Yeah.
And so certainly I think about, the things I think about, like Carolyn said, is the integrase inhibitors have been so powerful for us and we've done so well for so long. I want to conserve them if I can. So I'd kind of like to not use an integrase inhibitor first line in the future at some point. And then some of the other drugs, TAF, we have some concerns about. So maybe avoid some of those things. But the trouble is the things to avoid those, you end up using things that we don't have enough data on yet. And so I once had a partner who said, oh, these new drugs are so great, we'll never need anything else. And I was like, yeah, right. So.
Right. That's a good point. Others?
I think the option here is choice.
Yeah.
Is that it's not going to be a one fit for everybody. It's going to be a choice of what fits with their lifestyle, what fits with the cost. We're having, just at present, we're having all kinds of problems with getting lenacapavir for a patient that was on a trial trying to get them on Georgia Medicaid who won't pay for it. There's nobody in Georgia that's been able to get len on Medicaid. So that's a problem, and the paperwork is ridiculous. So thinking about things that are easy for patients to get and affordable, and what their personal choice is, I think is going to be the main thing than it is versus a regimen.
Right. Donna, do you have a point?
I would really like to have a regimen that's injectable, but it's one shot, one type, and can be done at home and by the patient, because we have such a problem getting the injectable now, and I don't see that improving markedly. So it would be nice to have the same modality of whatever you're using.
Yeah, I think it is aspirational to think about that. One thing I will comment on, we'll probably hear more about this later, but the sites that have been using injectable lenacapavir have had great results, as you've heard about. What hasn't quite bubbled to the surface yet is that there are some, not maybe many, but some patients who have intense pain at the reaction site during the injection and immediately thereafter. So, again, a one-size-fits-all is wonderful, but it doesn't mean it's going to all be right for people. Choice is what we're hearing, acceptability, tolerability, not jumping on the bandwagon too quickly, and not jumping off the bandwagon too late. Yeah, so it's kind of good to see, and I just said, put this case in there because of sort of prep you to think about what's coming tomorrow from Raj. So what regimen should I use as initial therapy in someone who's pregnant? A woman presents, she's 6 weeks pregnant as part of her prenatal evaluation. She's found to be HIV infected, viral load is kind of modestly elevated, CD4 count is 650, labs are normal, you have a genotype, no prior history, first pregnancy, okay to start therapy, understands the issues. So what is your first choice here? Go ahead and vote. This is a great example of how things change.
Mm-hmm. Yep.
Anybody have a clue about what this movie's going to be? You think it's going to be great? Okay. Why is it in 2 parts? Don't know. Yeah, nobody knows. That's Wicked for those of you who are struggling here. Okay. Whoa, okay. So initial therapy with BIC as opposed to TAF FTC dolutegravir.
I agree with the audience.
you're there. Yeah. So the data are emerging. Other thoughts?
I mean, the current guidelines as they're written would prefer the DALU plus.
TAF
Yeah,
FTC.
yeah. And I think, there's a place also for TDF3TC as well if you're not worried about any renal issues. But yeah, I think many folks who have such a great, experience, and their patients have a great experience with BIC-FTAF, I think I see the appeal, but, and I'm not sure if the guidelines, they might be updated to reflect that as well, but yeah, I don't know.
David?
Well, the only thing I would add is that the good thing is that it's getting easier because the guidelines for people who are pregnant are becoming much more like the guidelines for people who aren't pregnant. So a lot of good options that we have for standard antiretroviral therapy is now available. I will say one thing though, if you look at the data that has come out in second and third trimester, the dolutegravir levels are significantly greater than bictegravir, so that fact alone would make me want to choose dolutegravir, not just lack of data, but actual data where levels are significant. And they make that point in the guidelines.
Right. So I think that's kind of where we are. There's more of a lean towards this dolutegravir TAF FTC because there's a lot more data, and specific studies have come out that showed that it's effective throughout all 3 trimesters. The concern about bictegravir was as follows, but it leads to another question, which is somebody who's the same story, this woman got started on BIC-TAF FTC, then becomes pregnant. So in that case, based on what we've just talked about, would you continue the BIC-TAF FTC or switch to something else? And I think probably option D here would be the one that has the most data. So go ahead and vote. I've just biased you. Intentionally. If we had another breakout, could spend 10 minutes talking to you about the interpretation of Phantom of the Opera. It's really, most people miss that, right? There's actually a message there about how the world is unfair to women, but true. Okay, so most people would continue. Thoughts? Warm line.
Yeah.
Let's go to the warm line on the hot seat.
Very hotline. So I think I'm appreciating the distinction, right, between this case and the prior one, because the guidelines as they're currently written would give the option of continuing it if this is the combination that the patient likes and is working for them. I think we definitely want to sort of share additional information on the counseling, like what Dr. Spach mentioned, but as it is, you could consider, because we know also that pregnancy is a time that comes with additional stresses. Sometimes if you change a regimen with the best of intentions, it leads to unintended consequences, including viremia. So I would just make sure that I'm having just a real open conversation with the patient.
So David, how are you reconciling your last comment with the answer here?
I think I would have that discussion with the person, and if they're really happy on BIC-TAF FTC and they really don't want to take 2 pills a day, I would proceed forward, because exactly what Carolyn said, the data and the guidelines really suggest that people are on a regimen, they're doing well, they're probably going to do well. But I would at least inform them that if they wanted to look for the most optimal, that I would at least offer the dolutegravir and TAF FTC. And I think I would differentiate this from like an arm wrestle you might have over a 2-drug regimen or Cabril-Pivarine. So I think somebody like this is probably going to do really, really well. I think the big concerns are 2-drug regimens and elvitegravir-based regimens. Those are ones that I would have a different kind of a conversation.
Right. And the elvitegravir, if nothing else, because of the cobicistat.
Because of the COVID, yeah.
Of data. So to summarize, the world is changing. The question that I would have asked the same question in 2006, and we would have said, no, don't use efavirenz because of neural tube. And then by 2008, we say, oh, no, efavirenz is great. It goes back to the adage that there's often, in all of medicine, but especially this, there's a thin line difference between what's dogma and what's dog manure. So you got to keep that straight. And so the dogma changes, and what used to be great suddenly is not so great. So you can quote me on that if you want. But it's an emerging field. Okay, so should I recommend postpartum breastfeeding, chest feeding, the proper term, whatever. 30-year-old woman presents with, this is the same person actually, so now she's delivered, when she was diagnosed at 6 weeks, she's now delivered, she was started on dolutegravir TAF FTC, remains on that, viral load became target not detected, remains so, and she's doing great, and her baby girl delivered 2 days ago, and you get a phone call from the obstetrician asking if it's okay for her to breastfeed. So you say, yes, she should, nope, she shouldn't, you should discuss the pros and cons and decide, and then, or you're not sure what to do, go ahead and vote. From Hamilton, yeah. Okay. All right. You know, it's like standardized tests that say, yeah, it's always good to discuss. I mean, how can you argue with that? Right? Let's have a little schmooze over this. We'll talk about it. Kim, what are you telling your patient?
Yes, we would discuss, but if she's virally suppressed, and in terms of the data we have at this point, I would say yes, it's safe to let her breastfeed.
In my experience, they often come knowing they want to chest feed or breastfeed, and the idea is to make sure they understand it's not 100% protective for the infant. There's that 1 to 2% chance, so that's the point of shared decision-making I would go for.
Exactly, and that's what the guidelines say. It's maybe not even 1%. It's a sporadic number of cases that there had been, it was recommended, especially in sub-Saharan Africa, that breastfeeding be allowed, and there were a lot of really good, important cultural reasons for that. One is that if they weren't breastfeeding, what was wrong? People would notice, and then that created stigma and outing and that type of thing. But also it's healthy for the baby to get nutrition, and sometimes access to formula wasn't as readily available, so breastfeeding is a really important issue there. And then in developed countries like in the US, women were saying, wait a minute, why can't I breastfeed? And so data started coming in from sub-Saharan Africa, and it looked very effective and very little transmission. And those cases that had transmitted, almost all of them, mom's viral load had gone up. And so, okay, that makes sense. But in the last 3 years or so, there have been well-documented cases, only a handful, I mean literally a handful, where mom has had undetectable virus and baby became converted to seropositive and became infected. And so that small fraction requires a discussion, I think, is what the guidelines are saying.
And just to add on to that, Mike, and they did those studies and where they had the 2 out of the 500 transmissions, they actually had undetectable viral load in the breast milk as well too, telling us something about the transmission may be different and may be more cellular mediated. And I think I'm so glad we've gotten to this point where we finally have these kind of shared decision making around breastfeeding. But I also think we need to make sure conceptually U equals U in sexual transmission is not U equals U in breast milk transmission, or in people who are PWID who are, we don't know U equals there as well too. So I think the U equal U's message is perfect for sexual transmission, but it's not the same for breast milk transmission.
So themes coming out of this so far: shared decision making, choices are good, and dogma can be dog manure. Okay, how do I manage weight gain? We'd heard a lot about this yesterday, so I'm just kind of following up and maybe a real world kind of setting. This is a lady who started a big TAF FTC 12 months ago, had a great response, viral load went down, CD4 count bumped nicely, but also her weight went up, and her weight went up significantly from a BMI of 27 to now a BMI of 32, which is in the obesity category. Fasting glucose is not terrible, but the A1C is close to type 2 diabetes indication. So, besides diet and exercise, which of course everybody recommends and just makes people feel worse about their weight gain, what else are you going to do here, if anything? You change the antiretroviral regimen, go to metformin, bariatric surgery, semaglutide, which we heard about yesterday, some other option. Let's go ahead and vote. So Fanny Bryce, originally played by Barbara, you don't have to say her last name, right? She's like Sting or something. And then Leah Michele really killed it on Broadway as a second fill-in for that. Okay, so a lot of folks excited from yesterday, if not before. On that semaglutide train that's heading across the river on that train bridge. What, are there any guidelines yet or any things that tell us what to do here? Common sense? Let's make it easy. What do we know about switching antiretroviral therapy to improve weight gain? Not much. It ain't gonna work. Right? I mean, I think there's been enough studies now to show you can switch to whatever you want. It ain't going to matter. I mean, it doesn't mean the weight's going to go up more, but the most of the weight gain is in the first 6 months. And then once, this is kind of for everybody, once weight gain has happened, it's really hard to lose the weight. It takes a lot of work and effort. So what do you think? Kevin, you got an idea here?
Well, I was just going to say that this is something you probably should have talked about before you started antiretroviral therapy on the patient, because, again, the enthusiasm, people come in, they have HIV, at least to me, they're always like, oh, I'm going to die. And you're like, no, you're not going to die. We're going to be able to do this. We're going to do well. But sometimes we overlook talking about some of these side effects, and then when they happen, it's challenging because there's no data to say that changing the antiretroviral there's no regimen that's going to work in causing the weight loss. So then what do? Diet and exercise are great. Everybody doesn't eat as well as they should or exercise as much as they should, including all of us, but that's a different issue. But starting, at least letting people know that can happen. And also I think thinking about interventions earlier, but I don't know what all those interventions are.
So metformin, is that reasonable here?
I would use metformin.
You've used it for this?
You would use that metformin?
Yeah.
Yeah, fits criteria for metformin, and that's where evidence lies. And
Yep.
I'm a pragmatist, and getting semaglutide for this patient in this day and age is going to be a very hard thing to do.
Right. So she's borderline diabetic. Metformin would work for that. There are some data about weight loss with metformin, although it's usually modest, not big numbers, but some improvement in BMI. And maybe practically, to get the insurance to pay for semaglutide, a lot of times you have to tried and failed metformin in this setting. Talked yesterday about listing other risk factors, might be cardiovascular disease, hypertension, yada, yada. But the bottom line is, I think everyone's impressed with semaglutide. Yeah, Carolyn.
If I can just mention one thing, I think, and this was because I read something that was published by the WISE investigators over the weekend, but I think there's a lot we don't know also about sort of the transition sort of into menopause, and I think we will hopefully learn more that people assigned female at birth who will be premenopausal, peri, late, and then menopausal. I mean, I think my hope is we come to a more sort of nuanced understanding about timing with certain ARV starts.
Yep. It's a good point. So at the end of the day, it's a new modality. It's kind of exciting to read about, hear about. Those of you who went to Croy last year, I remember posters like around 790 or so. There was a whole slew of 5, 6, 7 posters that all were about semaglutide and went from improvement in fatty liver to improvement in heart disease to improvement in cognitive function. It sort of like did everything but cure asthma. And the point was you kind of walk away thinking, my goodness, this is like the second coming or something. So I think it's going to temporize. It's maybe your dad's point, Kevin, about don't jump on the bandwagon too quickly, but I think everyone is so eager to find something that will help, and it seems like this is something. It's an emerging area.
So I think the other problem is that she's 34, and getting insurance companies to do anything is horrible, that you can't prove these other things. And so I have learned the hard way about putting all those risk factors, but for a 30-year-old woman, there's not going to be many risk factors there. And they're going to say no. And so then the patient gets frustrated with the denials, and it makes them even feel worse sometimes in terms of seeing those constant denials. And it kind of perpetuates that she's in a situation she has no way of getting out of.
Right, and the other point is that we didn't talk about this, I don't think, too much yesterday, but once you go on, somebody goes on semaglutide, when you stop it, the weight
right
comes back. Yes.
Yeah, I just want to say as a pharmacist, please don't ever start anyone on semaglutide 1 milligram. They will puke their brains out. You need to start low and go slow.
Okay. I didn't hear that. Okay, good. All right. So now this is a common problem. It's not super common, but it's common enough that it sort of gets our attention, and we spend a lot of our time in clinics doing primary care and not that much HIV, but this is among the HIV things, something we struggle with a lot. So it's a 34-year-old guy who's a frequent meth user gets transferred from another clinic. And CD4 count is low and the viral load is high, and been through lots of different regimens, not taking his antiretroviral therapy regularly, which is what led to the viral load CD4 count. In the past, he's had some success, but it doesn't last very long. Clearly having trouble taking oral therapy, but you ask, are those regimens toxic? No. Do they bother you? No. And just doesn't take them. The only documented resistance is that you have from his records is M184V.
That's hard to believe.
So what do you prefer to do here? Go back to some of the standard drugs, maybe try lenacapavir orally with dolutegravir, or start injection of cabrelpivirine or some other thing. Go ahead and vote.
Do you use much Fostemsavir? They didn't give us that choice.
Company? Sounds like Sondheim. I can't place it. Okay.
With stunt Mike.
All right. So we have some who said, let's go back to our original tried and true one pill. They're having trouble taking medicine, but maybe that'll work, and it should work with an M184V. And then 33% are saying, wait a minute, this guy, despite his high viral load and the indication for cabrelpivirine in the package insert says you have to have them undetectable. So maybe the thought was get them undetectable and then go to cabrelpivirine. But starting cabrelpivirine with a high viral load, it's heresy. You shouldn't do it. But
We do it in San
We
Francisco.
do it anyway.
San Francisco and a few other places.
Yeah.
But tell us about the experience out there.
So, I mean, it really has been that we've had some of our patients who have never been virally suppressed despite, multiple regimens. And for those who are started at cabrelpivirine, it was a risk. And I think we did it in a very sort of controlled way, did very close monitoring for folks. And, there were most of the patients did suppress. And I think from a provider perspective, it was very gratifying, but also from a patient perspective, for those who have never been virally suppressed, to be able to get to that point was also like a transformative experience for them within HIV care. Now, I think it is monthly, not bi-monthly, because you're starting with a high viral load, and there does need to be close monitoring because there is a higher risk of subsequent failure. That I think with close monitoring. So our protocols have changed a few times because you're seeing these blips, and when you have a blip when someone starts out at a viral load of 200,000 with an injectable cabrolpivirine, you're a little bit more nervous about underlying resistance, particularly because this person has had exposure to integrases, as well as rilpivirine, so they might be harboring in a minor variant resistance to one or both of those agents. So I think in this scenario, I noticed that they were below 200 a few times. So, you could hedge bets and put them on an oral regimen for a month or two, and then transition them to cabrolpivirine if they're willing. But if they're not, then yes, I would just give them the monthly cabrolpivirine.
Right, so Monica Gandhi, who's actually Raj, who you'll hear about tomorrow, Raj Gandhi's sister, is the director of the Center for AIDS Research, or one of the co-directors in San Francisco, and out of Ward 86, came up with this idea, and I'm sure got ridicule for what are you doing, and she collected data and followed a small number of people, and became a larger number of people, and then so much data, in fact, that the IAS-USA updated in midstream, which is unusual, their guidance to sort of say, hey, if you got this situation like we just described, and you have not many other options, this is an option that you can try to employ. And it works for the most part. The obvious caveats are that it requires frequent visits back to the clinic, and maybe for the same reason the individual might have had trouble keeping up with oral medicine, they might start missing visits. And you're going to hear from Michael Mugavero at the last talk today about the importance and the meaning of a missed visit. It's pretty powerful as far as bad outcomes if people are not keeping their visits. But on the other hand, it is a way to success for a good number of people. And it just means that, again, we have to have conversations and chat about these types of things with the patients, but kind of thinking out of the box a little bit, this is an approach that could work for some.
And the missed visit issue, I think, is also often a reflection of our clinical limitations, not the patient's availability. And so in these scenarios, we actually do a lot of drop-ins, because folks do drop in for other reasons, and we sort of get them their injections when they happen to be there for an urgent care or for ADAP renewal or something like that. And I think that has really helped with, supporting individuals to stay on a regimen like this, because a rigid structure is often not going to work for our patients in a way that we need to support their adherence.
Yeah, and I was just going to say, talking about thinking outside the box, thinking outside of the clinic, right? Like, if anyone here is involved with really sort of street-based long-acting injectable, I just think that is it's such hard work, and just kudos to everyone who's committing to do this, because I think there are lots of patients whose lives are being transformed by us coming to them, right, rather than expecting that they are always going to come into us.
So maybe we should think really outside the box and start rewarding people for being undetectable.
Yeah.
With money. Well, if you think about it, we're trying to fix a problem with drugs that it is a problem with drugs, but we're trying to fix them with other drugs. But if you look at the cost of changing regimens, all these other things, there are some data that contingency management actually works.
Right. And I think we're obviously being very clear. This is an exception. This is an exceptional situation, but it's common enough to where we need solutions that are non-traditional. So this is something that came up a good amount, a little bit yesterday, and you hear about it otherwise. But here's the story. The 48-year-old guy who presented with HIV 4 months ago started on dolutegravir TAF-FTC. Genotype ended up being wild type, but the lab's normal. But then you look carefully at his hepatitis B profile, the surface antigen negative, surface antibody negative, core antibody positive, and HBV DNA low. Okay? Is doing well and now wants to simplify his regimen and go to cabotegravir or one other, like say, maybe dolutegravir FTC, 3TC. So what do? Do you change the regimen, keep the regimen the same, give an HBV vaccine and keep the regimen? It's okay to go ahead and go to these non-Hep B friendly regimens or some other choice? Very cutting edge question. Let's hear what you think. Another Andrew Lloyd Webber. You kept your distance. Okay, good. All right, so, wow, A and B. That's a very fun question. Carolyn, do you get that on the warm line at all?
We are getting it a lot more commonly with the two drug combos that aren't active against Hep B. So yeah, over time we are.
And do you have an answer, or do you want to?
We called you.
It's not a one size fits all. I mean, Hep B is just one of those fascinating viruses. For folks who don't know, I think the Hep B section in the OI guidelines did recently get an update last week.
Correct.
Were you going to go over that? Okay.
David, do you have an opinion here?
Situation, the data would suggest if you do not have Hep B surface antigen and you make a switch, your risk is going to be pretty low for reactivation. And that's very different than if you're Hep B surface antigen. What I would practically do if this person was in clinic, I would give them a dose of Heplisav B. I would schedule an appointment in a month to come back for their second dose, and then I would switch their regimen on that day. I would check an antibody titer 1 month later, and if that wasn't above 100, I would then give them a third dose at 6 months. And the last concept is your antibody goal with people with isolated core is different than everybody else that you're trying to vaccinate for hepatitis B. Hepatitis B are generally trying to get a surface antibody above 10. The isolated core, your goal is to get above 100, and that's what's different. And that's why I think Heplisav B was would be such a good choice, because it really generates higher responses. What I'm giving you about the titer is not my opinion. That's what's in the guidelines, and that's really the goal for above 100.
Fantastic answer. And what's changed here is some data has come in. And before we were, hand waving hypothetically, well, antigen, HB surface antigen is the culprit, and if it's negative, it's not so much risk. That is true. But the need for surface antibody also is helpful. So here are some data. It takes a little while to look at, but I'll just circle the two things that are important. Never Hep B surface antigen positive and always surface antibody. So antigen negative, antibody positive, that's your lowest risk. So somebody who maybe now has a surface antibody that's negative but had it before, they're at low risk. But the idea of vaccinating is key. And to get the antibody up, and the precision that you just said about the 100 is really a nice advice. Ever antigen positive, that's the worst group. Ever antigen, never antibody. So you don't really want to be in that situation. And then the other ones sort of float in between. So these are data that really, they were at ID Week 2 years ago, a year ago from this, in 23, but hasn't been published yet. So it's looking at the abstract, and this is out of the VA. But I think the concepts are really what's important, because last year, I think it was this conference, it might have been another one just after this, I raised the question of core antibody, and there was a lot of misunderstanding, and I think it's clear now, and Dave, you did a great job of explaining that. So again, not just the antibody, but also the antigen. Okay.
Oh, Mike?
Yeah.
We've had two recent cases of people that had HIV for a very long time, and they were tested for hepatitis B decades ago, and nobody checked them kind of recently, and they had lost their hepatitis B and reactivated because they were changed to a more contemporary regimen. So before the other point is, before you change, you need to repeat the hepatitis B testing. Don't assume that it was the same results that you had 10 years ago.
Right, and that's also a good point. With Hep C, it's usually you got it, and then there's viral load, and it continues. Hep B goes through phases, and it's not explained how and why. Yeah.
And Mike, the one point I probably should have made as well too, anytime you do make these changes, it's recommended that these individuals should get some monitoring, mainly ALT levels, and if they spike up an ALT level, then you really should check in hepatitis B DNA at that point. So it's not like you just make the change, you're good to go, don't ever think about it again. It is recommended to monitor.
Yeah.
Yeah, and I'll touch on this briefly also when I give my talk on Tuesday, but I think there was a group in New York that sort of as a practice-changing quality improvement activity, they actually put in some reminders exactly around that, just that, making sure that you have up-to-date, complete serologies prior to making any changes, and then acting on what those results are. So, and they showed good outcomes.
Okay. This is kind of straightforward. You got a person familiar to us who's well controlled on Big TAF FTC but has recurrent STIs every 6 to 12 weeks, and that has included sort of varying syphilis, GC, or chlamydia. Have a conversation, offer amoxicillin, offer doxy, offer cefixime. Go ahead and vote. Dear Evan Hansen, we've been way too out of touch. Yeah, I was expecting 99%, but yeah, I don't think we have to discuss this too much. It's been, Kim, you want to just say yes and we move on? Or what do you, what?
I would just say yes, but it can change.
Okay.
As we say, none of this 90 pills and 3 refills. That's ludicrous, if you ask me. So the issue is it has to be reassessed. STIs have to be reassessed. Patients have to be come in and get re-examined. I think the other thing I tried to bring up in the syphilis talk is that going the intermittent doxy can affect the clinical presentation. We don't know what the minimal, how long you need to treat. And so, again, you just need not to do it on autopilot. It's very effective, it works, especially for syphilis and chlamydia. Gonorrhea, there's concerns, which I brought up.
Yep.
And so one of the things I do also is I just put in standing orders for STI screening for these patients so they can just drop in and get testing. When someone has the frequent STIs, I generally will screen them once a month, oftentimes. And then I'm pretty aggressive in giving access to doxycycline. And so if someone is on 200 and if they're having sex every day, then they can take it every day. So I talk to them about doxy prep. Those are the scenarios in which I would have a conversation about doxy prep, which is 100 milligrams a day. It will cut their doxycycline use in half. And if someone is having like sex every day or every other day, that might be something that they're interested in. And having a lot of conversation about when they're using this and what types of encounters they're using it if they're not using it all the time. For example, I really encourage if there's any group sex activities that is absolutely where you take it on your way home, if you can, so that you have coverage, because that's really a lot of the data with PrEP. That's actually where you saw the highest risk of STI acquisition was when there was group sex, which was defined, I think, as more than 2 other people present, 2 or more other people present.
Okay, Dave?
I was just going to make one very minor point. So technically this says to have it after each episode. So the CDC guidance is pretty clear that it's not supposed to be more than 200 milligrams every 24 hours. So if people are having multiple episodes of sex in a day, doxycycline does have some toxicity. And so we really want to be careful that people know 200 milligrams in every 24 hours.
Yep. New skin lesions. Dr. Marr's on the front row, so we may turn to her, but this is a patient who showed up, I saw in clinic about a year ago, who had new lesions that you see here, reported fever, denied sexual activity in the last 12 weeks, which I scratched my head about a little bit, and he had been off art recently and has some substance use disorder with methamphetamine. This is a close-up of the lesion. I'll give you a hint that you've seen something like this already this morning.
All my patients.
Maybe more than once. So what do you think, what regimen would you prefer? Nope.
Yay.
Didn't mean to do that. No, we're not. No, we're going to start over. Let's vote.
It's all my patients.
Oh.
No.
Okay. All right. A very, very sharp audience. Kim, you wanna comment on this?
So I agree, we need to treat for syphilis. I'm also concerned about the way that it looks, and I'd be concerned about Mpox as well in terms of the way it looks. But the other things actually that have granulomatous ulcerative kind of looks to them would be chlamydia. And if you've not seen chlamydia look as a mass-like lesion, it can present like a mass-like lesion, and herpes would be the other thing that I would think about. I would also ask if there was a history of HPV or any history of anal warts, because again, we think about malignancy. You're not going to get tecovirimat right at this visit, most likely. But I would think about getting testing for HSV, monkeypox. I've also seen weird presentations of disseminated gonorrhea with this ulcerative, so I would actually swab the lesion as well. So test for everything.
Yeah. So we had access to the study for tecovirimat, and I thought enough of it with the fever history that this might be Mpox. So we did all the things you said, scrubbed the lesion. The Mpox came back negative. RPR was high. So this was syphilis, and these are side by side, and you can't tell, but there is a subtle difference between the Mpox and the syphilis. I was distracted a little bit just by the story, the look, the fever. I think your point, as I'm hearing you, and I think it's a great one, is that you can't just look at the lesion and know for sure. Even an experienced dermatologist gets fooled. And so, but I think there are some, the Mpox lesions are more plaque-like, at least in this setting here, not quite as raised. I had a case last week or 2 weeks ago of someone who just had these papules scattered. And I thought, and I was working with one of our advanced practice providers, and we both kind of scratched our heads and said, you know, why don't we just swab it for Mpox? And it turned out to be Mpox, despite the fact there was very little else. And we did not empirically treat with tecovirimat, but it's just all this is out there, and it's a challenge for us. And I think, number one, be humble, and number two, test widely for different things. Statin therapy, I think we all kind of know the data. We'll go through this quickly, but in this story, there's a 41-year-old diagnosed 11 years ago with HIV on antiretroviral therapy, undetectable, on a 2-drug regimen, doing well. Renal liver labs are normal. A1C is okay. Cholesterol is 210 with an LDL of 155. He's got hypertension, former smoker, and if you plug it into the standard Framingham cardiovascular risk estimate's about 2.5% over the next 10 years. So would you start a statin in this 41-year-old? Yes, no, not sure, let's vote. Well, this is definitely Sondheim, and so are we going to bring in the clowns? Are we going to bring in the statin? Let's see. Yes, 72% said yes. So I guess we bring in the statins. Anybody want to chat about this? Yeah, this is like, what's my line? Do you remember that? Yeah.
I'll just say, for patients of mine that sort of similar profile, like, young 40s, the uptake is not, not many people are enthusiastic about starting it. So, I'm trying to do better about having the conversation around the reprieve data and the updated guidelines, but I haven't had a lot of uptake so far, honestly. So maybe it's something I need to change with my counseling, but my patients are not enthusiastic about taking another medicine.
And I would spend some time talking about diet, exercise, and behavioral modification before I tried a pill, but I have the same experience. Most patients this age, they don't want to take their ART, but they make themselves, but adding another pill when they don't feel anything from it is difficult.
Yeah, and he's already on amlodipine. I just had this rule of thumb that for every decade of life that we live, we add another pill. So, so he should be at 4 pills now. So we gotta keep pace with that. Just to summarize, the reprieve study I thought was very striking. It took people from 40 to 60 or so years of age, and everyone's kind of, I think, seen those data, and a surprising 35% or so reduction in cardiovascular outcomes in people who were assigned the statin who otherwise would not have been on statins. And so I think the lean is towards that. The other thing about statins is that they seem to have some mystical anti-inflammatory improvement situation where it's hard to know exactly what it does, but it seems to go well beyond what LDL cholesterol is. So maybe we're learning something here that it's not exactly clear, kind of Buffalo Springfield for what it's worth, opening line. Yeah. Evan.
Well, I was just thinking if we're going to take fluoride out of the water, maybe we should put statins in.
with fluoride, yeah.
We'll take the fluoride out. We're going to take the fluoride out, so let's put the statin in.
Yeah. Substitution therapy. Yeah. David?
The only point I was going to make is that the one thing I think that was actually also really nice in the guidelines is they're very clear about if you're initiating this and people don't have a indication for a high intensity statin, this is really to start with a medium intensity statin. Right. So, rosuvastatin 10 milligrams, atorvastatin 20, this is not pravastatin at a low dose or really low dose. If you're going to do it, you jump in with a medium potency statin. And pitavastatin is not to be confused with pravastatin.
That's right.
And pitavastatin was used in the reprieve trial, which I've yet to see a prescription for pitavastatin, but you guys have it? You guys? Yeah. So it's not as widely used as rosuvastatin and atorvastatin, but not to be confused with pravastatin.
And in fact, I had several patients that couldn't tolerate any other statin.
And they tolerated
that drug.
And I think the dose is like 4 milligrams for that, right?
4 milligrams in the study, but we started slow. I started with 2 and then started going up, and they've been able to tolerate it. But again, I think it's a pill issue too. What I do is, if I get some pushback, I just show them the data. And I said, this is the data. You can see me now with the statin, or I'll see you in the hospital. It's up to you, thinking about, and then you can think about it. Yeah. Because they see the data. The data is amazing.
Yeah.
And I think you just have to tell them, the data's amazing, this is the data, you make your choice.
Yeah. And it's major cardiovascular events. It's not, stroke.
It's really
it's real disease.
And just show them the data. Most people are visual anyway, right? You tell them something, they're going to forget what you said. I just show them the data and look at this, and what do you see? And ask them to interpret the data.
No, but I think everyone's seen the data now, and it is challenging conversation sometimes because you're saying here's a pill that you're not really feeling bad for. It's a little bit like hypertension. And so these are the data, and basically the pitavastatin 4 milligrams, as we just talked about, 35% fewer events, and those events were major adverse cardiovascular events, first MI or first stroke. All right, when do I check for anal dysplasia, and when and how?
Really?
So a 35-year-old you're following, diagnosed 10 years ago, viral loads and CD4 count are fine. History of receptive anal intercourse, anal pap is abnormal. Referred for high-resolution anoscopy and noted to have high-grade squamous epithelial lesions, or HSIL. What do you recommend? Treat the anal lesion, monitor for 6 months, and repeat the HRA, or not sure? Go ahead and vote. Tevya. One long staircase just going up and another one just coming down. I would think those would be escalators, right? Think about that lyric. I never understood it. Okay. All right, so the majority say treat now, don't wait. Thoughts?
Exactly, that's what the Anchor study told us.
That's what it told us. Yeah,
Treat.
so this was first off, we should be screening everyone who's had receptive anal intercourse with anal paps. But the problem isn't so much even knowing what to do once you get to the high-resolution anoscopy. It's getting there, right? So how many folks, just by show of hands, do not have access readily to high-resolution anoscopy? Yeah, about half of the folks, and that's where the barrier is, right? Hyman, thoughts on this?
Yeah, so I mean, another question is when do you start screening? So, I take care of some younger patients, and, am I screening my 24, 25-year-olds, or am I waiting until, the 30, 35? So I think this person was screened at the right age, potentially, unless this was a follow-up. But yeah, we have access to, the UCSF Anal Dysplasia Clinic, which is one of the world centers for this. So we have access to send our patients there. But because of insurance issues, we actually had to have one of our oncologists working closely with us to start doing some of these HRA procedures, because we just couldn't get access. Like in San Francisco at our county clinic, we couldn't get access to these procedures. So I think there have been some creative things done by our leadership to ensure that our patients have access to it. But it's common, apparently, that this isn't something that all clinicians and patients have access to. But yeah, we treat this pretty aggressively at our clinic.
So, I mean, a lot of folks are performing anal paps, and then they come back abnormal, but what you're supposed to do at the next step is get the high-resolution anoscopy. And if you are able to do that, then the data are pretty clear. The red line is the red line is treating when you see the lesion. The blue line, in terms of badness here, is monitoring for another 6 months. So the anchor data were very powerful in terms of saying if you get to the point where you hope to get with high-resolution anoscopy and a lesion is seen, zap it then, don't wait. Part of the problem also, this is a study, so they actually got the people back, but you think about the loss of follow-up that you might have with folks to bring them back, and you've already missed the opportunity. So lots of reasons to do that. So, finishing right about on time, antiretroviral therapy should be initiated in general with an integrase-based therapy and as close to the time of diagnosis as possible. Weight gain is associated with initiation of ARV therapy, especially with integrase, but it occurs with all of them. And TAF seems to be a little bit more involved in weight gain. Semaglutide is actually the only intervention that has shown to work in a major way, but it's hard to access. We've heard some commentaries about difficulty with that. Metformin's another option. Dolutegravir is a drug of choice in general, for pregnant women. I didn't talk about this, but folate's really important for the neurotube stuff if you're worried about that, but it's a good idea for all pregnant women in general. And BIC is becoming okay, just not as much data. It's for sure if they're already on the BIC regimen after a conversation, continuing is okay. Breastfeeding is okay, but with conversation again. Starting rilpivirine IM is okay in the setting of a patient who is having trouble consistently taking oral measurement and with proper support. We've talked about that. And episodic doxycycline is effective in preventing STIs, but with all the caveats that we heard, especially when there's frequent sexual activity for exposures and challenges that creates. And so got a couple questions here. This one's talking about the core antibody positive with detectable viral load to be occult active, okay. Needing Hep B management is it doesn't give rilpivirine. And I think that's what a lot of people have said. That's kind of common. But I think the distinction between the antibody, the surface antibody in the past and no surface antigens is an interesting and important distinction. Yes, in the back. Not yet,
Yes.
but keep talking.
Okay.
Now I hear you.
Now that's really loud. I had two questions. Number one is surrounding ART start in patients who are already obese, already maybe struggling with diabetes. Are there any thoughts surrounding potentially talking to them about, non-first line therapies that avoid an NSTI and or TAF? That's my number one. And then my number two question was surrounding breastfeeding, that my research has shown that really it's mixed feeding that can cause issues. So it's more of like if you are gonna say, hey, let's breastfeed, then you need to stick with breast versus going breast bottle. But maybe I've missed the mark on that. So yes.
Okay, let's start with the first one about starting therapy in someone who's already obese. Carolyn, what do you say?
I am trying to change my practice so that I'm much more proactive and thoughtful about that. I mean, talk about showing people data that really is striking. I was just speaking with a woman the other week and said, hey, do you want to talk about BIC-FTAF? It's real tiny compared to what you're taking. But then I said, but what we're learning about is the weight effects. And this person was immediately like, nope. So I just think we're going to continue to learn about where the place is for our first line, because we've really been thinking about them through this very narrow lens, understandably so, about virologic suppression and overall tolerability. But again, everyone's different.
All right, and the second one about, was it breastfeeding? Yeah.
Might be me again. I'm sorry,
Okay.
y'all.
Right,
So the mixed feeding question continues to come up on our hotline. I think some of the data that we have on that probably needs to not be re-examined. We just need additional data because we don't know what it means. And I think from a practical standpoint, telling someone to exclusively breastfeed for months and months and months sounds great, but it is really hard for some people, and obviously we want infants to get nutrition. So I think if you have access to donor milk, human milk, that's great, but if you have to, give temporary formula, that's fine. And I would say this is where the question about do I want babies to be on some kind of antiretroviral as prophylaxis for that sort of layer of insurance that everyone really feels comfortable with, then that's part of the conversation.
Yeah, okay. Kim, I think this is a question for you. What do you think about self-swabs for anal pap or for STI screening?
Oh yeah, self-swabs are great. The problem with self-swabs, you're not looking at the bottom. So there needs to be people that are on this rotating, coming in and getting your own swabs are wonderful, but there needs to be some kind of look-see, because patients, if things are not painful, they're not knowing that they're there unless somebody looks at them. So that's for one thing. In terms of doing your own anal pap, I don't know that I feel comfortable with that in terms of their own anal pap. The other thing I was having some discussion about with a cytologist recently was about the differences if you're doing the anal pap, what comes first in terms of whether you're lubing up to examine the rectum. So you have to think about order as well. So, are you going to do a anal exam? And the anal exam is important as well to an anal pap. And so thinking about what you're doing, people don't like to do anal paps, but that's anal digital exams, but that's really, really important. Yeah. Anal pap misses stuff. If there's lube there, if the patient was recently sexually active and that there's something still in the rectum, those are the questions I like to ask before having somebody come in and do their own self-swab.
But I think to be clear, right, you want to do the anal pap before you lube up. That's a critical component, right? Anal pap, then lube. At least that's what the people from the ENs recommend.
No, that's correct.
Yeah.
But the problem is that, people who are very busy, who want patients to do everything themselves, I think it's a missed opportunity for us to find things, as well as, are they doing it correctly? There are nice patient-related ways to do it that some clinics have come up with, in particular at UW. You guys have come up with nice little placards in terms of how to do it. But again, I think you have to know your patient, know your clientele, and sometimes they try to get away with stuff, and then you miss stuff when you don't look.
Yeah, I also, in a place where we haven't had access to HRA, the digital rectal exams should also be a visual exam.
Yeah,
you
that's
said,
right.
because you do see things and biopsy them, and lo and behold, I found squamous cell cancers that are, the verge, that were visible.
Right.
And you can feel things, so it's really, it needs to be a more leisurely exam than often we do it.
Okay.
And I think I differentiate between anal cancer screening and STI screening. So I look at a lot of butts, and they're usually normal. And so I generally just send people out, because 90% of the STIs are going to be asymptomatic, and have them do the swabs. But for the anal cancer screening, I do think it's important to look, and it's an opportunity to sort of do an exam, identify issues that might come up that may be asymptomatic. But I think that we need to get more people screened for STIs, and decentralizing it is one of the strategies that seems like it's working.
That's a good point. Got two at the microphone, start in the back.
Yeah, just a quick comment. I've been doing this a week or two, and I've been talking to my patients about Reprieve, and to me that data is incredibly compelling. We have a new treatment guideline that came up really quickly because that data is so compelling, and I haven't had a single patient who has said, no, I don't want this statin if it'll decrease my risk of heart attack or stroke. I mean, to me, it's kind of a no-brainer. I won't give it to anybody that refuses it. But I think some of it is how you present it. It's really compelling data. I mean, we have studies that have an effect of 2 or 3%, and it gets published. This is a huge effect.
Yeah, that's a good point. And congratulations on your communication skills. They obviously are effective. As opposed to some people on the panel here.
Oh.
Yeah.
Hi. I wanted to elaborate on my question about the Hep B core from a second ago and see how you guys are thinking about this, because I've been, my colleagues can attest, I've been spinning out about this issue since Ryan White last year. So the way I have come to think about it, I have a patient population with just a high number of immigrants, so we're just rolling with isolated Hep B cores, negative surface antigens, and it became an equity issue with the ability to give Cabenuva. So where I landed after reading and going to a lot of lectures is if they're isolated Hep B core but a detectable viral load, I consider that occult Hep B, and that's requires Hep B management. But we usually don't catch that. Maybe we catch a viral load after they've already been on tenofovir for a while, so we'll never know if they were detectable. But if we do have a detectable viral load, that's Hep B. And then if it's just isolated core, like negative surface antigen, negative viral load, then I'm open to giving Cabenuva for that, because that's just a reactivation risk alone. But I do monitoring, so I'll check LFTs and maybe a viral load, a Hep B viral load here and there. But I don't hold Cabenuva unless there is a detectable viral load that makes me think they have either some kind of active Hep B. And I just wanted to get your thoughts on that, because, yeah.
Yeah, thank you.
Yeah, because this question was occult Hep B, not the isolated core.
Okay. All right, yeah, Dave.
Well, I think if there's actually, I tell you what the guidelines say with people with isolated core, they don't even recommend checking HBV DNA. And I think the case you presented, I wasn't sure if you were saying like low level, meaning it's basically insignificant. I think if somebody has a high level of HBV DNA, that would be different, but they should have surface antigen in that situation. They typically do, not always, but they, if they have high level HBV DNA. But I would say that would be a situation where what I would probably do in that situation would still do the vaccination, then I would probably repeat the HBV DNA down the road before making that switch. But I think you're raising a good question. I don't know that that wasn't addressed in the guidelines. I don't know if there's a right answer in that situation, but you can certainly, argue you would be more cautious in those patients if you know they're HBV DNA positive. But it's interesting in the guidelines, just isolated core antibody. Years ago, there used to be a mention about doing HBV DNA, but that's not in there. I don't know if you want to add to that.
Yeah, okay. I think it's not that common. That's good news, right? And it does come up, and I think the reason I put the case in is because there's more data coming out to help guide us. And the HBV DNA is, as I agree with David, usually is low, when the antigen's negative. And conversely, it's elevated. But
and it's often intermittent too.
That's all the thing. It always comes and goes. But thank you. That's a great point.
And I think the idea is if you raise up their surface antibody, that may be just enough to tip the scales in that situation.
Right.
But,
The only other thing I would be concerned about is if they're coming from an area of high endemicity of Hep B, like Africa. Certain countries have very high incidence of cancer from their Hep B, and thinking about family history and things. So there's other things in terms of thinking about that to individualize it to that patient to make sure that they don't have any other risk factors.
Yeah, I've mostly been erring on the side of giving people Cabenuva for the core,
We have 3 people at the microphone. We're at the end of
I'll keep
time.
talking about this
Okay,
forever.
And I want to be fair here. Maybe we can come down front and we can talk to you about the individual questions, but I want to make sure that, because we only have a certain amount of time for lunch, but if you want to come forward and ask the question.
My comment is very short for people that are interested to do anal pap. They have to be polyester. They have to wet it with plain water, and then you have to rotate it about 8 to 10 times.
Yeah.
That's it.
Good, thank you. So there was a couple questions about latent TB. Dr. Spach will talk about that in his talk. We'll reconvene for the afternoon session at 1:55. Thank you.